Hey all, welcome back to the Real Life Pharmacology Podcast. I am your host, pharmacist Eric Christensen, and I thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got a free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher, no matter where you're at in your healthcare professional career. So again, reallifepharmacology.com. Simply an email is all it's going to cost you, and we get you updates when we've got new content out available, like our Flippin' Pharmacology flashcards or our Pharmacology crossword puzzle book, both on Amazon. All right, let's get into the drug of the day today, and that is phenobarbital. Brand name that I have heard most is Luminol, and this is an older anti-seizure medication or anti-epileptic medication. Mechanistically, it is a barbiturate, so it's going to basically depress the action of the brain in a general sense. So sensory cortex, it's going to reduce motor activity, obviously cause sedation, and ultimately, being an anti-seizure medication, that's what we're trying to do, is to kind of blunt that activity and obviously reduce the incidence of seizures. So that's the primary use. It's not a drug that I see terribly often anymore. It's a really, really dirty drug as far as drug interactions, things of that nature, which I'll certainly get into. But I do see it occasionally in pets, or I have seen it occasionally in pets for seizure control as well. So definitely used in veterinary medicine. Dosing of this medication, I've seen in the range of 60 to 200 or 300 milligrams per day, usually in divided doses 2 to 3 times per day. Usual kind of dosing or target might be 2 milligrams per kilogram per day. So that's kind of a guideline to note. But we check drug levels, and I'll talk a little bit about that in further detail up ahead here too. But that's certainly a good way to monitor as well as clinically. Like, are they having adverse effects? Are they having ataxia? Are they having, dizziness, excessive sedation, things of that nature? Dosage forms, oral solution, injectable, and tablets. And with that, let's get into some of the adverse effects. So first and foremost, there are 3 boxed warnings with phenobarbital. So first, opioids. So potential for an additive effect. So essentially you could classify it, I guess, as a drug interaction. So adding on a drug that has sedative properties like phenobarbital on top of opioids can increase the risk for respiratory depression, overdose, and ultimately death. Phenobarbital is a controlled substance. There's risk of physical dependence and significant withdrawal symptoms if stopped abruptly. And these can be life-threatening. So if you're ever working with a provider, or you are a provider considering getting somebody off phenobarbital, maybe they've been on it for a long, long time without seizures or, something to that effect, definitely make sure you know what you're doing with tapering off this medication, because withdrawal symptoms, like I mentioned, there has been certainly reports of life-threatening withdrawal if you get too aggressive with it. And then the last box warning, risk of kind of abuse and misuse. Certainly that ties in with controlled substances. Adverse effects. So I've alluded to a few of them already. So certainly sedation, anytime you kind of blunt the central nervous system, that can be an issue there. Ataxia, maybe memory impairment, more confusion. In my geriatric patient, that's probably something you're going to see a little bit more often, is that kind of worsening confusion, particularly if drug levels creep up, dizziness, and most of these adverse effects are going to be dose dependent. So obviously the higher the dose, higher the levels, it makes sense, the more likely you're going to run into that. There have been some reports of potentially increased risk for suicidal ideation and maybe worsening of depression, so that's something to pay attention to if you know your patient has a history of those mental health issues. Rare adverse effects, so skin reactions have been reported. There are a few genetic variations in certain patient populations that may increase the risk of significant skin reactions. Even SJS, Stevens-Johnson syndrome, has been reported. HLA-0101, HLA-B 1301, HLA-B 1502 are some genetic variations that may be at higher risk. So those are always good board exam questions to think about, particularly maybe higher level board exams like BCPS and things of that nature. So definitely pay attention to those genetic variations in relation to phenobarbital adverse effects. Other adverse effects I've kind of alluded to a little bit. So even without opioids, respiratory depression is a dose-dependent effect. Usually it's going to be with IV administration that we're worried about those more acute, severe issues. Other effects like that, cardiovascular risk, there is some there. It can drop blood pressure and drop pulse. And again, particularly with IV, more aggressive doses, that type of thing. So that is definitely something to pay attention to as well. Other potential things that you may hear about reported, megaloblastic anemia, and I'll talk about that in drug interactions a little bit. And hepatotoxicity has also been reported with phenobarbital. All right, a little bit about the kinetics. It does have a long half-life, so in the neighborhood of at least 2 days. Saw one resource report 53 to 118 hours. So half-life is definitely in the neighborhood of days for most patients. So it's got a very, very long half-life. It is excreted unchanged in the urine, approximately 25 to 50%. It has some metabolism by CYP2C9 as well. Minor CYP2C19, CYP2E1. Drug interactions on phenobarbital itself aren't probably a major concern, but as I'll talk about ahead here, phenobarbital is an enzyme inducer. So that can lead to a lot of changes in a lot of different drug concentrations. One last thing on monitoring, well, a couple things. Trough concentration, that's typically what's monitored. There isn't actually great data on where that exact value should be. At least there's not specifics in relation to efficacy. So where that trough concentration can really help you is if you've got a patient that's stabilized and we get that baseline concentration. Okay, they're not showing signs of toxicity. And, they seem to have clinical efficacy, whether it be, maybe they're not having seizures or something. That's a good thing to have and a good thing to know. So let's say that value is at 20 micrograms per mil. So again, we're having clinical efficacy, or at least we're seeing that, and we're not having adverse effects. Well, now that's probably a good target concentration for that patient. So that can vary a little bit. Generally, what you're going to see is a reference range between 10 and 40 micrograms per mil for kind of that target therapeutic. But again, it's there isn't a ton of data with this being an older drug that's a perfect target range for every patient. So keep that in mind. But again, that baseline level when patients aren't having adverse effects and are having clinical efficacy may be helpful there. Generally, we're very concerned about toxicity if you're getting 50 micrograms per mil or higher. So that's definitely a situation where we're probably going to run into toxicity. Other monitoring parameters, LFT, CBC, renal function, and I do want to mention some of the vitamins, vitamin D, B12. You may want to periodically check those levels, particularly if patients having issues or displaying any signs or symptoms of deficiency or anything like that. Folic acid as well. That's where that megaloblastic anemia came in. Was this drug is or has the potential to cause folate and B12 deficiency as well as vitamin D deficiency. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like PCPS, ambulatory care, geriatrics, BCM-TMS, NAPLEX, go check out meded101.com/store. We've got a great list of resources there. Tons of referrals, testimonials now, so we're really appreciative of that. If you're not a pharmacist, definitely go check out meded101.com/store. We've got a list of great resources, flipping pharmacology flashcards, pharmacology crossword puzzles, all sorts of different books and resources that may be helpful to you in your pursuit of learning pharmacology better. So again, all the purchases there go directly to support this podcast. All right, wrapping up with drug interactions. So I left off with monitoring vitamin D and folate and B12. That might be something you want to look at periodically. So I would classify that as a drug interaction. So phenobarbital can cause deficiencies in multiple B vitamins, B2, B6, B12, vitamin D, folate, calcium. Calcium, vitamin D, that's obviously something I get concerned about in our geriatric patient population, particularly with osteoporosis risk. Folate, B12 deficiency, certainly anemia risks, as well as other potential adverse effects with deficiency there. And then probably the most notable thing with phenobarbital, it is a CYP3A4 inducer. So that is a big concern when it comes to the efficacy of other medications. So amiodarone, for example, apixaban, an anticoagulant, many HIV medications, warfarin, another anticoagulant, and many antipsychotics, antibiotics like the macrolides, clarithromycin, for example. So there's tons of medications that can have its concentrations reduced when we're using phenobarbital. So that is really, really something to pay attention to. I obviously did not go through an all-extensive list here. So if you see somebody on phenobarbital, my strong suggestion would be to run a drug interaction screen for that patient. Okay, very, very important. You want to make sure that we're not, changing and wrecking the concentrations of other drugs like amiodarone or anticoagulants that are going to be obviously very, very important for the health and safety of our patients there. Other drug interactions, so CNS depressant activity, alcohol, opioids, sleepers like trazodone, Ambien, those medications, they can have that additive effect and increase the risk for that excessive sedation. One other thing I always look out for with any patient taking a medication for seizures or that's being used for seizures is other meds that worsen seizures. So bupropion is kind of the classic example that you'll always see show up on board exams and things of that nature. So definitely pay attention to that if phenobarbital is being used for seizure purposes. All right, well, I hope you picked up a few clinical practice pearls today. If you enjoyed this episode, found it helpful, please do us a favor, leave a rating review on Amazon, iTunes, Spotify, wherever you're listening. We appreciate those ratings and reviews. Definitely helps us reach more people. If you want to reach out to me, Eric Christensen, mededucation101@gmail.com, or Eric Christensen, PharmD, BCPS, BCGP on LinkedIn. With that, I am going to sign off for today. Thank you so much for listening. And as always, please support the sponsor, meded101.com/store. Take care and have a good rest of your day.